Hello, everyone, and you are very welcome to the 2024 Scope Patient Wellbeing Seminar. We are delighted to be here with you, and a big warm welcome back to those of you that attended last year, and a big welcome to those that are attending for the first time. My name is Adele Duffy. I am Head of Medical at Scope, and I'm joined by some great colleagues and experts today with a great lineup for you. Just to look at the lineup again, the agenda, we're going to be talking to experts in contact lenses, in terms of makeup, in terms of communication. And joined with me today is my colleague, Mandy Davison. Mandy is an optometrist in London, and she runs a dry eye clinic. And she is joined, and there's another room behind us full of optometrists and experts in the area that's going to help address your questions. We do our best to answer as many questions as we can. So we can't get to everything, but we'll do our best to try and represent your question. We always get lots of questions on individual medications and treatment plans. We cannot comment directly on the medications, but we'll do our best to help you in any way that we can. So on that note, I am going to start with Mandy, because Mandy, you joined us last year. And a lot has happened in the 12 months. It seems very fast, but a lot have actually happened. And after last year's event, there was one key topic that kept coming back, IPL as a treatment. So I just want to chat to you regarding IPL. But before I do that, I know that we're going to get lots more questions this year, probably in IPL and other topics. So if you could all just add your questions into the Q&A box on your screen. And the chat function is more to make general comments. But if you have a question for one of our experts, please put it into the Q&A box. And again, we have a lot of experts here ready to answer your questions. So on that note, Mandy, IPL, remind us what IPL is.
Yeah, I think it's a really good idea to just maybe go over IPL, a little bit about the basics, because IPL, LLLT, there's lots of letters. What do they all mean? And actually, when's the best place to use them? So IPL is intense pulsed light. And that's when you have controlled pulses of high energy light delivered to the skin around your eyelids. Now, IPL is a really effective treatment for the type of dry eye where you haven't got the right quality tears. So if you've not got enough of the oils that make up the outermost layer of your tear film, IPL can really help, because it stimulates the little glands, the little oil glands that live in our eyelids that produce that top layer of tears. So the IPL, you have your pulsed light around the lower eyelids, and that reduces inflammation in that area. And also you get a bit of heat that liquefies the oil. You may have been told to use a heat mask at home before, where you warm up the oils, but IPL is kind of a supercharged version. Now, there are lots of different pieces of equipment that you can do it, lots of different machines. And you can see on screen here, there's a selection of a few of them. Some you require a gel to be put on first to sort of help cool the light. Others, the machine I have, you don't, you just have a cartridge that does it. So that's IPL. Now, how do you have IPL? What goes on in an appointment? What we're going to do?
Yeah, absolutely. So we've jumped straight in here with IPL because it was such a big topic last year. And I suppose we're just looking for the last 12 months. But Mandy, last time people were wondering, how often should I go? When should I talk to my healthcare or eye care professional about it? So just to step back a little bit, because a lot of people are going to go and try it, okay, in the last 12 months. So let's say how often, when to start, what to watch out for.
Yeah, definitely talk to your specialist about it. I talk to all my patients at the point of diagnosis. If I feel that they've got a problem with their oil glands, then I will mention IPL, because I'm fortunate enough to have the equipment in my practice. Now, it is becoming more and more popular in the UK and Ireland. It's very, very widespread in the US. We are catching on to it in the UK and Ireland over here now. So I always talk about it. I think it's worth having the conversation. Sometimes patients have been trying the low-tech versions, the heat mask, and it's not really working for them, so we might consider it. Other people don't think the heat mask is going to be for them, so they opt for IPL straight away. Now, you do need to maybe have serious conversations about it. It is high energy light. So there are certain contraindications. So, for example, if you're pregnant, if you have photosensitive epilepsy, if you have any metal piercings around your eyes, that's not good to have heat energy. And if your skin is particularly sensitive to sunlight, that can cause problems because it does make your skin perhaps a little bit more sensitive. So we go through all that, we have the conversation, answer questions, and then if we decide it's right for you, then we sign you up to 4 treatments as like a loading dose. So you can do those treatments depending on what piece of equipment you've got. It can be between 2 and 4 weeks. I usually do them at 2 weekly intervals, so we book in those 4 sessions. Now, the one thing you do have to be mindful is that you have to keep out of the sun. Don't sun worship at that time because your skin will be more sensitive. It's a case of being vigilant with sunscreen, factor 50 on your face, sunglasses, protect yourself if you go out in the sun for 2 weeks before the first treatment and for 2 weeks after the second. It's not a scary treatment to have done. This is a picture of me with one of my patients. Now, it is light energy. You do need to wear protective goggles. So the patient has blackout goggles on, I wear goggles, and the whole procedure just takes 2 or 3 minutes. It's just little 5 doses of energy. So I'm going to stop there and move on to low level light because I use the 2 in conjunction with each other. And this is when we have a mask with certain wavelengths of light that you sit behind, and you can see the mask there on your screen, and it warms up the eyelids. It creates a heat. It penetrates into the tissues. It creates a heat from inside. And that again reduces inflammation and helps to really melt that oil and get it expressing out of the gland so it can do its job properly again.
Okay. So you recommend you would use both interchangeably, or?
Yeah, you can use them both as standalone,
Okay.
and there are studies to say they are both quite effective as standalones, but they have this synergistic effect if you use them both together. So it's almost like a double whammy and you get the best of everything. So yes, I would usually use the 2 as a twin treatment.
So exactly on cue, thank you. We've got questions coming in already, Mandy. The first question of this seminar is it painful? Is IPL painful?
Not really. Some people experience pain differently. Some people don't really feel anything. Some people feel hot. Some people say it's a bit like an elastic band pinging against your skin. Nobody has ever said it hurt. I don't think it hurts. But you are aware of a little bit of a sensation. It's just like a microsecond.
Okay. And Mandy, another question in, do you do IPL on the lower lids and upper lids? Or what way, if you're going, what should you expect?
So there's different devices that have different protocols.
Okay.
So some you do the upper lid as well, and then you have to wear a really protective or like a shield in your eye. So it's almost like a big contact lens that protects you from your eye from the light. But a lot of the, or certainly the machine I've got and some others is you just treat the bottom because it actually magically helps with the top glands as well. And of course, if you're using the low level light mask, then that heats the whole of the eyelid as well.
Okay.
So it depends where you go, what
on the machine and the protocol.
Yeah.
So basically, it's on the basis of who you go to
Yes.
and what machine they have.
Yes.
Okay, perfect. And we have another, just this lady has tried IPL, and she actually didn't have to use eye drops for 6 weeks, but she just feels she's deteriorating now. She does have punctal plugs as well, but she's just like, you mentioned their top-ups. So you do 4 treatments. And then what about top-ups, or how often then after your 4 weeks, every 2 weeks? You need
so I am led by the patient.
Okay.
So I would usually do my 4 treatments, and then I will put a 6-month appointment in the book. If they notice a change before then they can come back sooner. Some patients can go a year, but everybody's very individual. I've done top-up treatment. I've done a second treatment at 3 months, 4 months, if the patient has felt the symptoms are coming back. So on individual merits.
Okay. Mandy, we'll move on from that. I'm sure we'll get some more questions in ILP, and we come back to them at the end. Mandy, just before we finish up, just one other big thing that happened in the last 12 months, or it got probably more awareness in the last 12 months, is digital devices and their impact.
Yes.
And their causation of dry eyes.
Absolutely.
So just give me a brief little 3 things maybe there.
So the big thing this year was the TFOS lifestyle reports. So the Tear Film and Ocular Surface Society produced all these reports about lifestyle factors, and one of the big ones was the digital eye strain. So digital eye strain, looking at screens, can start within 20 minutes of looking at your digital device. It's not phone, not just a phone, it's not just a screen, it can be anything. So we need to be mindful of that. We need to be mindful that if we're looking at a screen, we blink less effectively, we don't blink completely. If we're not blinking fully, we're not spreading those oils over our eyes that we're trying to treat when we do the IPL. So it's really important to remember to blink. It's really important to have your screen at the right distance, to be looking down maybe slightly at your screen, and to have regular breaks from it. And the prevalence actually is 70%, we've estimated globally. So it's a big thing. We need to look after it.
I think, Mandy, you have a slide there with a QR code that if anybody wants to go and look up these reports for themselves or get more information,
Absolutely.
they can.
Yeah.
Mandy, sorry, but you say blink. We all blink. What do you
Yes,
mean?
but when we blink, our eyelids have to meet. So the top and bottom lids have to touch. Those little oil glands, those precious glands that we're trying to keep healthy, are situated just behind our eyelashes. And what happens is you get little puddles of oil form on the top of them. The lids meet and they drag that oil. So every time we blink, we recreate that top layer of our tears. We do a half blink, we're not spreading it, and the tears can evaporate.
So blink properly. Blink properly.
And regularly.
Okay. And regularly. Okay, thank you, Mandy. Okay, we're going to move on to the next session now, and it is with Mr. Connan Tam. Connan is actually a dry eye specialist in London, but he's joining us today from actually Canada. So he was here last year. There we are. Hello, Mr. Connan Tam. How are you? Nice to see you.
Very good,
Thank you for joining us.
Nice to see you.
You were on last year. Oh, well, yeah, we'll always have you back. We'll always have you back. But there was one patient last year that was on this particular webinar, and she was listening to the information that you presented, and she was like, I need to go and see Mr. Tam. And I chatted to you at a congress there a few months ago, and I just thought it would be great if you could come on and share that patient's journey after they came to you. Because one big thing is, who should people go to and who's the right expert?
Yeah.
So, Mr. Tam, you're going to bring us through, let's say, what quite is probably a medical case study in terms of how you would look at signs and the symptoms. But really it is to help people identify signs and symptoms themselves. So I know you have a few slides prepared. So we'll go through them then, and we can discuss at the end. Is that okay?
Yeah, sure.
Perfect.
Sure. So shall I give a bit of a background first about the patient? So she initially presented to her dentist about a mouth ulcer, and because it wasn't healing, she underwent ultrasound, which some of the glands were found to be atrophied, and at that point she was suspected to have Sjögren's syndrome. And having seen a rheumatologist, she was then confirmed with Sjögren's syndrome in November 22. At that stage, she was asked about any dry eye symptoms, but she didn't. She only described them as being sticky. She attended her local opticians who suggested that she had dry eyes and gave her some drops to use. She then joined the Sjögren's Society, which is where she heard about the Scope event last year. And having, as you said, already attended that, she decided to have a full dry eye assessment to look for preventative measures. So let me just have a look here. So in the initial assessment, she had been using artificial tears, but we very quickly found that she had a reduced tear volume and reduced tear lipid layer. We go to the next slide. If you have a look at the image here, you can immediately see that the lid changes had already happened, so indicating some long-term changes already. The lids are a bit thicker here. You can see abnormal blood vessels because of inflammation, and you can even see some eyelash misdirection. And go to the next slide. With fluorescein dye, you can see that she has some damage and some dry spots on the cornea and on the conjunctiva, which is the see-through membrane over the white of the eye. And again, if we go to the next slide, please. Using infrared imaging, which we call meibography, you can see that there are some mild gland changes here. On the top one, you can see the glands have become more tortuous, a little bit thicker, maybe even more fluffy, less defined looking, and you can even see the odd one that's shorter. when we expressed the glands, we found that the glands were yellow and slightly cloudy. Next slide, please. And again, because she didn't describe any real dry eye symptoms and she wasn't really given any instructions beforehand, we decided on conservative treatment. So we advised her to use drops during the day, minimum of 4 times a day, a gel at night as well to protect the corneas during her sleep, and to perform some warm compresses daily. And at the follow-up, she was actually more aware of the impact of the dry eye on her vision, being more smeary towards the end of the day. And when we examined the eyes, that she did actually have more mucus on her tear film, and the glands still produced the thicker and perhaps even more cloudy looking meibum. And again, tear volume remained to be low. So we then assessed her with expression, and immediately it gave some relief to her symptoms. So we decided on treating her with inserting punctal plugs to the lower lids to improve the retainment of the tear volume, and then booking her in for a course of IPL treatment, which began at the beginning of the year. And at the third follow-up, at the third IPL follow-up, if we go to the next slide, please. She was, have you changed the slide yet? She was found to have improved meibum quality. The volume of the meibum improved. And then in March 24, we actually found that she had narrow angles, which is a risk of a type of glaucoma. So we referred her then to an ophthalmologist who decided on early lens extraction, which is like an early cataract procedure to reduce the risk of glaucoma. And before the surgery, she came to see us, and actually we discovered that she had a bit of a flare-up of inflammation again. So on alerting the surgeon, which was important before the surgery, the surgeon decided then to treat it with a course of steroid drops. It's important to have that control before any surgery to the eye. And so we moved to currently where she's had the surgery, and actually she's then really developed more dry eye signs. And so currently we're at the stage where we're doing the top-up IPL treatments as Mandy described before.
Thank you. And thank you. I think the person that you're presenting is actually on the call today. So I just want to say thank you for allowing him to details. You mentioned IPL there again, and we've got more questions. Like,
really sorry, the volume's just gone down a bit. I'm not sure if that's on my side at all.
Okay, so I'm just going to speak a little bit louder. So I
Oh,
hope you
got
can
you
hear
now.
me.
You're loud and
Oh,
clear
great.
now.
Okay, I won't shout as loud then. No, just regarding IPL, somebody was saying there, they went through, they got IPL, they got LipiFlow, and they're not finding the benefits from LipiFlow. I mean, is that somebody that you would recommend IPL for? And do you think they'd have success with that?
Yes, I mean, I think when you're dealing with more of an inflammatory component to dry eye, treatment like IPL can address the inflammatory problems. So I think that's, a good option to try. And some people would even combine the LipiFlow with IPL. So I believe in the US currently, a lot of the people adopt the protocol where you do a full course of IPL followed by LipiFlow to extract more of the meibum out of the glands as well.
Okay, so potentially an option for further treatment.
Oh, absolutely,
yes.
Yeah.
Okay.
Yeah.
Have you experienced people having any side effects of IPL?
Side effects from IPL, no. I think it's all about careful patient selection. As Mandy said before, we have to ensure that the patient hasn't been subjected to high levels of UV, and the skin tone needs to be correct. those who are photosensitive or on drugs that are causing photosensitivity should avoid it or delay it until it's suitable. So otherwise, there are no
Okay.
side effects that can happen if you select the patient carefully.
Okay. Just one last question, Mr. Tam. You mentioned that this patient needs to go for surgery, and is there any, let's say, time after surgery where you'd recommence IPL? And I got another question, and somebody was going for cataract surgery actually, and they're just wondering how long after surgery can you commence IPL for dry eye?
So I often tell patients to, because they're under the care of an ophthalmologist, to do that. I do seek their opinion, but I personally would say about a month afterwards is a perfectly safe time to do it. And actually, more importantly, if the patient has dry eye signs leading up to surgery, it's important to treat them beforehand to ensure a better outcome, visual outcome.
Perfect. Thank you so much for sharing that. And I hope people found that useful to see how you brought somebody through a journey and the signs and symptoms. And actually, I'm going to move on now to the next. Mandy is going to have a session. And Mandy, I suppose we just heard from Mr. Tam there regarding how he needs to communicate with rheumatologists and other people involved in the care of the patient. But let's say you're going to speak with someone now regarding, let's say, how people can ask and have effective communication for themselves with their eye care professional.
Absolutely. It's something we're asked a lot. It's something I'm asked a lot, is how do we get our professionals to understand maybe exactly what dry eye is impacting us day to day? How can we give them all the right information, and how can we get the most out of our appointment, I guess? So I'd like to welcome Peter Campton, a colleague of ours from Scope. Peter works across the company in the UK and the US. He's an expert on communication skills. So he's going to, chat to us a little bit about how we can make things easier, make our journey easier, and how we can get our message across to the consultants when we go and see them. So thank you for joining us.
Thanks for having me.
And I think that we've all been there. We've all been into an appointment somewhere. It might be a medical appointment. It might be a solicitor. It might be the bank manager. And we've come out and we thought, oh, I never asked that. Well, I wished I'd answered that differently.
Yeah.
How can we make life easier for ourselves? How can we stop that happening?
Great. I'm glad you asked. So we'll divide it into 3 distinct periods. So before, during, and after the consultation. So I think, first of all, it's important to remember there's no magic pill that's going to cure all of your symptoms straight away. The key is to have a consultation, a discussion with your optometrist to explore the best outcome. So it's a two-way thing. So there are a number of things you can do beforehand. So definitely keep a list of all of your symptoms and note them down. Particularly make a note of any of the symptoms that will disrupt your day-to-day activities. They're the things we really need to resolve. Secondly, prioritize those symptoms. So the ones that have the most impact on you, but not forgetting the ones that you might think, well, that's not worth bothering them about. That might be quite small, because in there could be some really good clues to help the eventual diagnosis. I think it's also really important to write down any specific triggers. So does your dry eye happen is it more often in a warm, dry room, or is it more likely to happen when you go outside? And then the fourth thing to make a note of it really clearly as possible, particularly if it's a product that you've tried, to write the brand name and explain that to your optometrist, even if the person that you're speaking to is the one that recommended that in the first place. They won't be offended, and that will help them look for alternatives.
Yeah, I mean, that's a lot of really, really useful information there. I think as a clinician, the more information that you can bring into me to build a picture of your life, the easier my job is. Tell me what you've tried before. Tell me what's worked, what hasn't, what you quite liked, but you stopped, or even, don't hold anything back. And this the point you made about a symptom that you thought was maybe not important enough to mention. Sometimes they are the most important.
Yes.
So write absolutely everything down. I'm never offended. In fact, if somebody's got a list, I'm delighted. And I think it helps as well if you get nervous or overwhelmed when you're in there, you've got that to refer back to. Anyway,
Yes.
we've done our homework. Okay,
Absolutely.
we're there. We've got our list.
Yes.
We've turned up at our appointment.
Yeah.
What do we do now?
Well, and as you say, it takes the nerves out of it because you know you're not going to forget everything because you've got everything written down. So make sure you refer to your notes, or you could even hand them over for your optometrist to read. Be prepared to ask plenty of questions and be as open and answer the questions that you'll receive as fully as possible. It's also really important to make sure that if you're feeling something's not been covered fully, to actually pause and you can say, actually, can we revisit that a bit, please? I don't fully get it. We haven't covered that as fully as we would like. And then perhaps I'd like to understand a little bit more about this. So really good, clear questions that signal to your optometrist that actually you'd like a little bit more information. And then I think a really important question at the end is, when can I expect to feel relief of these symptoms? That's a really key bit. If someone asks you that question, why is that an important question?
I think it's setting realistic expectations. I think, don't go away and think this isn't working within a week and it's not going to work. It's much better you understand that it is going to take time. It is going to be slow.
Yeah. And
I think it's really important that you understand that as a patient, and as a clinician, we should be sharing that too. But to your point is, it's so hard when you think people are understanding something. You can check in with them and they do get overwhelmed. It's a big deal. They get very nervous. I'd much rather somebody say to me, can you repeat that? I don't quite get that. I write things down for people.
Yeah.
It's information overload. Ask your clinician to write things down if you don't understand, but please question anything you're not sure about, because it's so much easier for us to deal with it while you've got us one-to-one.
Yeah. And that's what this is all about, is getting that successful outcome, isn't it?
Yeah.
So that's during the consultation, and then afterwards, there's still things that you can do. So keep that same diary, keep a note of your symptoms as you're going forward. Make a note of what you feel is really working, and then I think the other really important part is share the successes for your next consultation, because your optometrist will want to know that it's been successful and they've found a solution for you. So make sure you've explained that fully as well, and prepared to share with them next time.
Excellent. And the diary, come back, feedback to me, tell me what's worked, tell me what hasn't worked. Makes our job a lot easier. I talk to my patients about partnership. We're in this together. I can help you. You need to give me the information to help you. You're there as a team with your clinician. So work with them, because at the end of the day, we want the best outcome for you. So that was brilliant. Brilliant insights, Peter. Thank you so much. And hopefully that's made things a lot easier for you. Now, if you have got any questions about communicating or anything that you're not sure about that when you've been in an appointment, please pop your questions in the Q&A. Peter is coming back at the end to join us for a general Q&A session, so we can put some questions to you again then. Thank you, Peter.
Absolutely. Thank you, Peter. I think one core question from me that you said there, can you tell me a little bit more, or I need to understand more? And that it, because you're trying your best to understand and take as much on as possible. And you're you don't want to come across as, well, I'm not listening to you, or I don't want to
there's so much.
But there's so much. Thanks a million. Actually, there was so much last year regarding, let's say, how to use eye drops, how to clean your eyelids correctly, and also how to massage your eyes. We've got another scope optometrist that also runs her own clinics to actually prepare a few videos for us on that. So we've got 3 little videos now to show you regarding massaging, eye drop usage, and cleaning your eyelids with wipes.
Today, I will guide you through the process of massaging your eyelids after using a heat mask. First, ensure you have used your heat mask as directed by your eye care specialist. The heat helps to soften the oils in your meibomian glands, making the massage more effective. After removing the heat mask, your eyelids will be warm and ready for the massage. Follow these steps carefully. Start by thoroughly washing your hands. Place your finger just beneath your eye and roll up towards your eyelashes, applying gentle pressure. Repeat this motion along the length of your eyelid. Then repeat the whole process twice more. Now for the top lid, closing your eye, place your finger just above your eye, below the brow bone and roll downwards, applying gentle pressure. Again, repeat this motion along the length of your eyelid. Then repeat the whole process twice more. Now, repeat this process for the other eye. Remember, you don't need to press too hard, as the oil should be warm. Because you release these oils in your tears, you may experience temporary blurring of your vision, but this should clear with a few blinks. By following these steps, every time you use your warming mask, you can effectively manage your meibomian gland dysfunction and improve your eye comfort. Today, I'm going to take you through how to use eyelid wipes. Begin by thoroughly washing your hands. Open a packet of the eyelid cleansing wipes. Wrap the wipe around your finger and carefully clean your bottom eyelid in small circular motions, starting from the inner corner near the nose and moving towards the outer corner. Make sure to clean the base of your eyelashes where debris and oil can accumulate. You may find it easier to use the mirror. So now let's do the upper eyelid. Gently close your eyelid and again start from the inner corner and move towards the outer corner using gentle circular motions, ensuring to get to the base of the eyelashes. Now repeat the process for your other eye using a fresh wipe. Using eyelid cleansing wipes regularly in this way can keep your eyelids clean and help reduce the symptoms of eye discomfort. Today, I will guide you through how to apply your eye drops. Begin by washing your hands. Remove the cap from the eye drop bottle. Be careful not to touch the tip of the bottle to keep it sterile. If you're using the drops for the first time, press the base of the bottle until the first drop appears at the tip. This primes the bottle and it's ready for use. Tilt your head back slightly. Hold the bottle in one hand, positioning it directly above your eye. Use your other hand to gently pour down your lower eyelid, creating a small pocket. Gently press the bottle to release one drop into the pocket of your lower eyelid. Avoid letting the tip of the bottle touch your eye or eyelid. After applying the drop, close your eye gently for a few seconds to allow the drop to spread evenly across the surface of your eye. Repeat the process for your other eye. You may find it easier to use a mirror. After applying the drops, replace the cap on the bottle.
So thank you, Indy, for making those videos, and you're actually joining us in the studio.
Thank you.
Indy, when I was looking at those videos, 3 really great videos on how to, and the practical advice. When you're in clinic, which one of those aspects or videos do people get, I suppose, wrong or incorrect the most?
I think it tends to be the massage is the most common one that I think people don't sometimes struggle with it a little bit more. So the way I've said it in the videos is how I explain it to my patients in clinic. And I reaffirm it every single time. Make sure you're doing the massage after you're doing the heat as well.
So I'm going to be writing here, how is it done incorrectly? How is it done wrong?
I think the 2 important things I think about is time and technique. So firstly, making sure that you're doing that heat for the consistent enough amount of time. So normally we say 10 minutes. So making sure you're doing for the 10 minutes. So imagine you've got butter, you want to melt that butter. So that 10 minutes will do that. And then making sure your technique is correct. You're in the right place. So you're making sure that you're actually by the eyelids as well and not underneath, and making sure that you're rolling it like you roll a tube of toothpaste to make sure you're getting all that oil out to make way for fresh new oil to be produced.
When you say heat, you're talking about a heat mask or something like that beforehand?
Exactly, yes.
Okay.
A heat mask, something to heat the eyelids with.
Okay. And I suppose from looking at the video, it's quite intuitive to roll that way. Like, is there another way to roll it up? You know, you were saying before, maybe the circular motions. And
Yes,
things
so
like that.
some people tend to roll in circular motions, but if I think about it, the way the glands are set up are bottom and top like little soldiers. So you want to roll up rather than go in circular motions, because the circular motions isn't going to push it up the same way that you're going to get from the rolling technique.
Great, thank you. Well, now that you've done the videos, they will be available and we'll be able to share with you after the event. So thank you, Indy.
You send that.
I'm now going to hand over to Mandy, and we have somebody joining us, for another expert joining us virtually. I'm really interested actually in this because I have my contact lenses in now, and I do feel I need to go and get the drops and apply them, Indy, like the way you said there. But Mandy, I'll leave you to speak with the contact lens expert.
Thanks, Adele. And yes, I'm delighted to welcome Mr. Cian Gildea, who's an optometrist who works between the Eye and Ear Hospital and the Wellington Eye Clinic here in Dublin. And he's
Hi, Mandy, how are you?
I'm very well, thanks, Cian. We're delighted you're here, and you're going to talk to us a bit about contact lenses because it's confusing. Sometimes you can't wear your contact lenses because they feel way too dry, and sometimes actually you're given contact lenses to help you if you've got dry eye. How does that work? Hopefully you're going to sort of unravel this mystery for us a bit. And I think maybe before we do that, we need to just understand how dry eye affects people with contact lenses.
Yeah, exactly. So it is a paradox, and it is quite confusing. It can be quite confusing. And I know in TFOS, they have a tiered structure in how to treat dryness. On one of the first tiers is actually stopping contact lens wear, and then I think on the third tier it's resuming contact lenses as either bandaged contact lenses or sclera contact lenses. You go, how is this possible? But if we look a little bit first of all at the tear film itself and the contact lens. So a contact lens is roughly about 70 microns. And so how big is 70 microns? 70 microns is about the width of a human hair. And your tear film, so the tear film roughly between 5 and 7 microns. So a tenth of the width of this contact lens. And what happens when you put a contact lens onto the eye is it actually splits the tear film in two. So you have a pre-contact lens element and a post, so underneath the contact lens element as well. And what we know then is, so the tear film being made up of 3 layers, you have your lipid or your oily layer, which stops the evaporation of the second layer, which is the water layer, followed by the mucus layer, which kind of attaches it to the cornea itself. So what happens to this outer tear layer, we'll call it, is that it becomes more unstable, more likely to evaporation, and the lipid layer itself is almost non-existent over a contact lens. So this is why we can get issues with evaporation, these other problems that we can run into with contact lens wear. So, and if we move on to the next slide here. So you can see here on the left that there's no contact lens on the eye. The image on the right, we can see that the contact lens on the eye, the tear film becoming thinner pre and post lens, and friction being a huge issue. So it's the pre-lens tear film is the most associated with contact lens discomfort. So issues with that aspect of it is most associated with contact lens discomfort. It is quite difficult to measure or to assess what's happening underneath the contact lens. But what we do know, or the evidence that we do have, knows that the pre-lens tear film is associated with discomfort. And one of the big things is friction. So if your eye, think again back to our blinking, how much do we blink a day? And if our eyelid is going over, so it's about what 10 to 14,000 times a day, I think is on average is how much we blink. And if your eyelid is going over that surface that amount of times, and it's causing friction, that's going to do damage and cause issues. It's important to, and if we move on to the next slide as well, actually, don't get too bogged down in this. There's an awful lot going on. But what we do know is, I have it circled here, is that contact lenses are associated with dry eye disease, ocular surface disease. And it's not just the tear film itself, but it's the lids, it's the meibomian glands, etc., etc. And there's not one single element of a contact lens that we can attribute to, okay, that's the issue there, and then kind of disregard everything else. it's multifactorial, and I think people need to realize that. So friction is a big thing. If we move on to the next slide as well. So I'll talk a little bit about this in a second, but friction is a big thing. The modulus of the lens, so the stiffness of a lens, okay? So if you have a stiffer lens, you can get more issues with your meibomian glands, gland dropout, affecting the quality of the meibum. That's interrelated then again with our friction. Gas permeable lenses have been shown to cause more issues compared to a soft lens. The other things in terms of the actual contact lens itself is the material, the water content, the lubricity or wettability of the lens, how well a lens wets in your eye. If it has more of a water content, it's more prone to dehydration. You have to look at the fit of the lens. Is the lens fitting well? The edge profile of the lens, a rounded edge versus a knife edge. And then you look at the environment as well. So there's patient factors. So age and sex are going to have an impact. Medications are going to have an impact. What you're using the lenses for, or what environment that you're in when you're wearing your lenses, all of these things are going to have an impact. So before anybody gets to wear a contact lens, you need to have an assessment. There's an issue now with people self-fitting. And because they're viewed as a commodity and not necessarily a medical device, which they are, people just self-fit. They'll order off the internet and they won't, they'll be set up for failure essentially. If we look at this slide here, contact lenses are intrinsically inflammatory. So they can increase the surface temperature of the cornea by up to 2 degrees. So what happens is you have to weigh up what contact lens is potentially going to do to the ocular surface. A daily disposable tends to be the best. Reusable soft, so a monthly lens or a 2-weekly lens, because you're using solutions, and that's another thing that you have to think about, what contact lens solution are you using. We have to think about compliance. So do you really stop after 2 weeks of wearing your 2-weekly lens? Do you throw it out after a month, or do you keep it going for another few days? Do you top up your solution when you should be replacing it on a daily basis? And do you keep your contact lens cases, etc.? Do you keep them clean?
No, that's great. That's lots of factors to think about there, Cian. So if we just move on then to think about why we might wear a lens, just briefly, to help us with dry eye. Are they different, these lenses? Are they different to the ones that we get from, the internet?
Yeah. Well, one lens that I would try it's a different set of circumstances. If we move on to the next slide, actually kind of sums it up. There's 2 different types of lenses that you can use for people suffering with bad dry eye, bad ocular surface disease. You can use soft bandage contact lenses, or you can use things called scleral lenses. And scleral lenses are large, hard lenses. They tend to be about 17 to 23 millimeters in diameter, usually a larger diameter for ocular surface disease because it covers more of the ocular surface. And it's essentially with these lenses, if you look at the picture on the left there, they're kind of more synonymous with people who would have, say, maybe corneal issues, etc., or people who've had corneal transplants, but they're very effective in people with severe dry eye. And essentially what you do, it's a hard lens. You fill the bowl of the lens up with preservative-free saline. This can be topped off with any lubricating drop that you would like. You can put, say, autologous serum drops in the bowl of the lens as well. Some people would put maybe an antibiotic into the bowl of the lens as well, to help with issues if they have if they have a compromised cornea, say, for instance. And the tear exchange under a scleral lens is very low. So essentially you're getting your eye is being bathed all day. And it can be very, very effective at rehabilitating and protecting the ocular surface.
That's
So
excellent. Oh, sorry.
yeah, so I mean, there's a recent study now, and there's over 62 indications for these scleral lenses.
No, that's great, Cian. That I think that explains it beautifully, doesn't it? It's bathing the eye, so it's a completely different type of fit with that type of contact lens. So hopefully that's explained things a bit there. Thank you, Cian. That was really interesting.
Yeah. And I have a few questions coming in, so thank you, Cian, but we'll come back to the questions maybe at the end, but you're exactly on cue. I got a question in on scleral lenses and you popped up the slide, so you're all in sync. So just thank you all, keep the questions coming in, just remind you to put them in the Q&A box and we'll definitely get back, and I'm here getting them as well, so lots of questions coming in. So Cian, you'll hopefully join us now in a few minutes after we speak with Dr. Laura Periman.
Of course.
Perfect.
Thanks,
Thank you.
Cian.
Thank you. So Dr. Periman, thank you for joining us.
I'm here. I've been typing away like crazy in the Q&A section.
Thank you so much, as you always are, and we are so glad to have you back again this year.
My honor and privilege. Thank you for doing this for patients. It's such a refreshing and service to this incredible community of dry eye patients. I really respect it and I really appreciate it, and it's an honor to be here.
But we're delighted to have you here, and I suppose this can only happen, and I can only ask the questions by people listening and asking the questions. So the audience and attendees are doing great. Dr. Periman, we spoke last year a lot about cleansing and the importance of eyelid hygiene and blepharitis, etc. Okay, when I look back at the last year, actually the stuff that's got the most press for dry eye disease has actually been makeup, in terms of cleansing, but also makeup itself. Now, I have heard you present nearly all around the world on this topic, and we could talk for an hour, but we actually don't have it. We have about 5 to 6 minutes, so we'll do our best. But can you just tell me, firstly, before I talk about taking makeup off, about putting makeup on and any issues that you've seen with patients regarding the application of makeup?
Yes, clearly I enjoy makeup. It helps me feel a little brighter, more awake. But yeah, it does have, excuse the pun, a dark side. We use these products to exacerbate or to highlight our features, but yeah, they can have significant issues associated with it.
So what kind of issues have you seen? I know you've got some great pictures, so this is your warning, everyone. There's some gruesome pictures coming up, but this was something that you saw when they came into clinic. So explain, how did make this happen?
This is so interesting. So a lot of our dry patients struggle to wear cosmetics, and we're sort of not exactly talking about that demographic. There's stuff coming that's directed to that, but for now, let's focus in on some of the complications that we see with cosmetic use. This was on a physician chat group one Saturday. A colleague said, "Hey, I got this thing on my eye. What do I do?" And I'm like, "What are you using around your eyes?" Turns out they were using a new mascara that has nylon fibers in it. Now that is a man-made product, but when you look at them under the scope and under high definition with electron microscopy, high resolution, you'll see that they look a bit sharp and like spears. And this is an example of nylon fibers lodging under the conjunctiva. There's actually medical case reports of nylon fibers lodging in the conjunctiva, causing all kinds of trouble. So I think we may see a little bit more in the next slide what I'm talking about here. And what tipped me off on this particular aspect of cosmetic complications, we'll call it, was patients always ask me, "Dr. Periman, what mascara can I use?" I'm like, you're asking me to make a recommendation. That's a high bar, right? To come from an ocular surface disease specialist and a cornea specialist. So I started looking and I approached this scientifically. It's like, okay, well, could I use a microscopic assay to help look deeper, excuse the pun, at the different compositions of mascara and maybe use this as a way to predict irritancy potential in our dry eye patients. And I was shocked to find the appearance of nylon and rayon fibers in many of these formulations. So I thought I had this set on do not disturb, please, pardon. There we go. Hopefully that'll be quiet now. So if you go on to the next slide, I'll show you a little bit more what I mean. So on one of the slides that, one of the formulas that I tested, there are those white or those clear areas next to the red arrows. Can you see that on the left? Those are actually nylon fibers and this was a very high concentration in this particular mascara formulation. And under electron microscopy, you can see they're sharp little spears. Now, if you are a dry patient, you don't have the lacrimal volume, the tear volume you need to flush these out. And as things dry, you can catch an edge and create a lodging into the conjunctiva, creating inflammation, fibrosis, etc. So I always recommend a nylon-free, rayon fiber-free formulation for mascara. Go on to the next slide here.
Dr. Periman, just on that one, how do people know if a mascara contains a nylon? Like, is this an ingredient on the side of the pack, or how do we choose a product and know?
So
what to
it'll
avoid?
say nylon or rayon in the ingredient formulation. So I think that's an important particulate that is important to make sure that you're not being exposed to. Sometimes when I epilate eyelashes looking for Demodex mites in blepharitis patients, I'll actually see leftover fibers in patients who have removed their makeup. So even wearing it and then removing it doesn't necessarily protect you from the potential impact of these particulates.
Okay, so read the packaging. Read the packaging.
Read the package. That's right.
Yeah. Okay. Okay.
So
Okay. Next
another,
picture.
yeah, here's another common myth. Tight lining the waterline blocks your meibomian glands. How many times have you heard that?
Lots.
Turns out it's not true. We actually had, and we did this experiment. We did this really cool experiment where we took a whole bunch of waterproof eyeliner and we went right along the waterline, got it nice and thick and goth looking. And then we did neural stimulation and we're actually able to see meibum being delivered through that makeup layer. So it's a myth that waterproof eyeliner on the waterline blocks the meibomian glands. It's simply not true. However, patients may have the accumulation of debris from improper removal, and we'll talk about that a little bit later. And this is an example of a significant amount of leftover cosmetic debris on an instrument called a golf spud that's used to basically snow shovel off this excess debris in makeup wearers. Other cosmetic pigments can actually lodge in the conjunctiva and could create chronic inflammation and fibrosis. This is a patient who used kohl, traditional kohl, K-O-H-L eyeliner, which is, culturally significant in some cultures, but used the homemade formulation and has significant tattooing and lodging of these pigmented particles in the conjunctiva. And this is one of my patients. So yeah, it's mascara can lodge. It's called a mascaroma, and sometimes it mimics melanoma. When the Shields and Shields out of Will's eye did a retrospective chart review on ocular melanomas, and about 1% of them were actually mascaromas or mascara embedded pigmented debris.
Okay. So if people want, so that we're getting a lot of questions in number one, can you wear makeup? But yes, you can wear makeup. But I think the important point is, Dr. Periman, it's like you need to make sure you remove it and remove it efficiently. So do you want to just talk a little bit? We're getting a lot of questions in there.
I'll bet. I'll look in a second. I'm trying to stay focused.
No, you stay focused on me and I'll ask them. But right, makeup, you can wear makeup, but a key thing is about the cleansing or taking it off.
Yeah, and I'm so glad you're bringing this up. So we'll talk about adequate removal, but there's been a movement to identify single ingredients in cosmetic formulations. And that's actually a false starter. It's not the individual ingredients, it's the total composition, the total contact time, the way that it's applied, the container that it's kept in, the contaminants such as particulates, fungus, virus, bacteria, all of these different things, all of those elements translate into cosmetic ocular safety.
Absolutely, absolutely. So if we move on then regarding the removal of the makeup, because I think you have we have this slide, but we're just going to have to move on a little bit.
Okay, sure.
We're running out of time. I'm so
We're
sorry.
running out of time. Okay, let's do it.
We're running out of time. We're running out of time. We need to put you first on the agenda the next day. But
All
you
right.
know, when we talk about removal, I mean, you have this lovely picture, and I'm sure everybody can see it, but you just want to talk to that picture regarding irritation around the eye.
Yes, so this, sometimes we like to do a full glam look, right? And so this is a patient who with, you know, the full eye makeup look and a lot of irritation from her cosmetics wear. And so this is just a photo of the different things we did in office to get that makeup off. So the top is her in full glam makeup. The next one was with a makeup remover wipe. The third one is after a gel formulation and a microfiber cloth wipe. And then the final one is after a device called New Lids with a cleaning gel, which is like almost like an electric toothbrush for the eyelids. It has this little silicone rotating brush, does a brilliant job at getting that final bit of makeup off. But look how much effort it took to get this off. Now, if you look even more closely, you'll see in that third photo down that the skin is a bit red, right? And some of that is from the mechanical rubbing effect that was necessary to get this stuff off. Now, the good news is there are smarter ways to get makeup off without having to put so much elbow grease into it that interrupts and disrupts this delicate skin of the eyelid area. And Scope has gone to the trouble of custom formulating and innovating a brilliant preservative-free micellar formulation makeup remover that does a beautiful job of doing the hard work without the mechanical friction component. So you put it on a cotton ball, you soak it real good, you set it on there, and when you're wearing this much makeup, you need to let it sit for a little bit, right? Let it sit on there, let it start breaking up some of that debris, and then you can gently wipe it away with far less friction. So I find that to be a lovely adjunct for my makeup loving patients, male or female, I don't judge.
No, absolutely, absolutely. And I think, you know, actually we just had a comment in here that somebody says they have their eye area ruined due to rubbing.
Yeah, we do see there. This is such a delicate area,
Yeah.
and there's like delicate little tendons that suspend your lower eyelid, much like a hammock. And that
Yep.
little tendon can be stretched and come off from its delicate attachments to the orbital rim. So yes, excess rubbing can definitely contribute to eyelid damage.
Okay, perfect. Dr. Periman, we're actually going to bring all the panel back in now because we
Great.
have lots of questions to address. When we're bringing everybody back in, I've got one question for you. A lot of questions regarding tinting the eyelashes. Yeah or nay?
Use extreme caution.
Okay.
These are ammonia-based colorants, much like covering up the roots of
Okay.
the hair. And those will be very irritating to the ocular surface if they leach into it. So use extreme caution.
Okay. Okay. So I think I get your message loud and clear. They'd be very, very careful. Okay. Okay. But you can wear mascara because a lot of people want to
Yes,
know what's
certain
in it.
formulations. Yep, you want to look for a formulation that doesn't run and smear, that especially if you put in an artificial tear, and many of the clean brands or the brands marketed to dry eye patients really run and smear, and that gets into the tear film based on our little microscopic study that we did.
Okay. Okay. Okay, so I'm just going to, I've got a few more questions. Also, Cian, you're first up. Cian's joined us again there. Cian, thank you. How common is it for an eyeball to be unable to tolerate a contact bandage?
So, and there was another question in the comment section as well.
Yes.
So it's about balancing up what's going to what position you're coming from. So if somebody would have, say, low or moderate dry eye disease, you won't necessarily need to use a scleral lens, which has the potential to cause more inflammation because you're not hitting as much or not trying to treat as much inflammation or as advanced disease. That's why a soft contact lens would actually make more sense in that case. Compared to somebody with Sjogren's syndrome, for instance, who would have an awful lot of ocular surface inflammation, aqueous deficiency, then the balance of putting a scleral lens on that eye makes more sense because the potential benefits are there.
Okay, thank you. I know these all questions are very random at you, so if anybody else wants to contribute, please do. Or say, Edel, I'm knocking that one back to you. Actually, Mr. Tam, you mentioned flare-ups before of Sjogren's, and it was pre-op that there was a flare-up. This patient suffers 2 to 3 times a year with herpes virus flare-ups in my eye. Dry eye condition seems to exacerbate this condition. Any advice? This is painful. So any help at all would be appreciated.
I think the importance of maintaining a better tear film can minimize the discomfort caused, but I think in the end of the day, it's urgent treatment for the flare-ups that's required, and that does often require medical treatment, urgent attention, and it's important to maintain the treatment for dry eyes, but on the peripheral, the most important is medical treatment when necessary.
Okay, thank you. Mandy, I think this one may be for you. I have tried several dry eye drops with no improvement. My GP sent me to an eye specialist, and she told me my eye ducts were blocked. She did work on my eyes to clear my ducts, but there was very little improvement, if any at all. My eyes are always running with water.
Okay, well, I assume that means the tear ducts, as in the eye ducts.
Yeah.
So there's 2 reasons why your eye can water. Well, there's several reasons, but a lot of the time it's because of this defective oily layer from the meibomian glands that we talked about earlier. So if we know that the drains are open and they should be draining effectively, it's probably that it's a problem with the oily layer and that we need to start working on improving the health of the meibomian glands. So I would suggest you talk to your doctor, your optometrist about the heat, cleanse, hydrate, like Indy explained, or think about something like IPL. I suppose the other factor is that as we age, our lid architecture changes a little bit. Sometimes if our lids sort of start to droop and turn outwards a bit, that can cause excessive watering. But for the most part, I would investigate, the lids, see the health of the meibomian glands and see whether we can improve it that way.
Dr. Periman, we have so many questions regarding IPL, and I just remember from last year you had some great input regarding IPL. So, there's a few people here, like, is IPL suitable for people with pigment dispersion syndrome? Are there some people that are just not responsive to IPL treatment? So I suppose you've seen so many as well. Just if you could talk to that would be great.
Absolutely. So pigment dispersion syndrome is a condition inside of the eye that clogs the fluid drainage trabecular meshwork. It's much like having the gutters on your house cluttered with leaves, and now the fluid can't drain. That's a totally different disease state than what we're talking about for use with IPL. IPL is intense pulse light. It's not a laser. And there's multiple different platforms for applying IPL energy, and there's multiple techniques as well. So it's technique dependent and technology dependent, but it is a workhorse for addressing the 6 interrelated mechanisms of meibomian gland dysfunction. And I call them the BSTO, RAR. This is laughing at your warm, wet washcloth, right? You've got to get after the BSTO, get all 6 heads. So the BSTO is bugs and bacteria, such as Demodex. E is enzymes. The biochemistry of meibum is very altered in MGD. Inflammation surrounds the meibomian glands. Cytokines diffuse across the basement membrane and make the meibomian gland stem cells abnormal in their functioning. So we got to clean up the inflammation. S is stasis, or the easier way to understand it is constipation of the oil glands. Everybody understands that word.
Yeah.
E is altered melting temperature. That's why we often recommend warm compresses, but not every patient can tolerate a warm compresses, particularly if you have rosacea. That heat is an exacerbator. So I don't make my rosacea MGD patients do warm compresses. And then finally, obstruction. So if those are the 6 interrelated mechanisms of the besto, IPL gets 5 out of the 6 heads, which makes it the most broad spectrum choice for addressing MGD associated with dry eye disease. Powerful approach.
Thank you. I nearly feel this conversation in general, the meibomian glands are key in the last 12 months regarding IPL, digital devices, you know, nutrition, etc. I don't know who to ask this question, so whoever wants to take it or if no one wants to take it, just one person just asking, their mum has rheumatoid arthritis and they're just wondering, is it possible to have Sjogren's without having rheumatoid arthritis? I don't know if any of you have come across that.
Yes, I mean, I think it's primary Sjogren's can happen. I think when it's related to rheumatoid arthritis, it's classed as a secondary. Please correct me if I'm wrong, but absolutely, yeah.
I would say to you that the autoimmune dry eye patient, I have yet to see one who does not have MGD. Now we're classically taught this is an aqueous deficiency problem. Well, it might start that way, but you quickly then involve MGD as well. So some of my happiest IPL patients are those that have either primary or secondary Sjogren's because I'm able to address their meibomian gland dysfunction.
Which is why in the patient that I showed, that's why we chose to do IPL as well as tier reservation.
Awesome.
I mean, it's unusual to have one form of dry eye disease exclusively. Usually a mix.
Actually, Cian, when you're talking there, just I got another one in there about scleral lenses. What's the process for getting scleral lenses fitted?
So when they make an appointment, obviously we'll have a look at the eyes, we'll measure prescription, etc., and things like that. There's 2 different ways of doing it. One is a diagnostic set fitting assessment. So you'll physically put lenses on eyes and take measurements, etc., and order a lens. But now there's actually new technology where we take 3D maps or molds of the eye, and then we can have lenses designed based on that. So that's more of a bespoke approach to it.
Thank you, Cian. Laura, or Dr. Periman, I'm going to come back to you for a second. There's a lot about makeup, and let's say I think people nearly felt they couldn't wear makeup anymore with dry eye. So we talked about what it can do and how to remove it. But let's say, have you any tips, let's say, for choosing a makeup or how to apply makeup that may help a dry eye patient?
Yes. So the patients who have had to drop out of cosmetics use, we use a stepwise progression back to cosmetic use. Number 1, get the dry eye and MGD under control. Like you can use the most expensive mascara in the world, but you've got to get the underlying issues under control. That's step number 1. Step number 2 is to slowly add on different products and find ones that you tolerate. So that number 1 requested item is mascara, and you'll want to find a formulation that does not run and smear, that will stay put, not flake, not run, will withstand the use of an artificial tear as well. So that finding that formulation and the performance varies wildly. And as we discussed earlier, you'll want to make sure you're avoiding formulations that have nylon fibers and rayon fibers in them, particularly if you're a dry eye patient. So start there, get the dry eye under control, the inflammation under control, the MGD under control, and then start searching for a mascara formulation that you tolerate.
Thank you. I think, Peter, this reminds me of, you know, asking the right questions. And it's not just asking the right questions of your healthcare eye care professional. It's like ask it of your labels, ask it of your routine, you know, just question. Is that right? And be open.
Absolutely.
Adele, if I might add on one idea to this particular topic, we did a study looking at dry eye symptom scores in patients who removed their makeup every night and those who did not. Those who did not remove their makeup every night had much higher speed scores than those who did. So back to this concept of concentration, contact time, formulation, all of these things, context, make sure you remove your makeup every day, right? You've got to get that stuff off of there. And again, hats off to all of you for coming up with such a innovative, gentle, effective formula.
Thank you, Laura. Well, on that note, in our time zone is quite late now, so I'm going to go and have to remove my makeup quite soon because we're at the end of this event. So I wholeheartedly thank each one of you for the expertise that you've brought today. And I will just say that thank everyone else for adding the questions into the Q&A box. All I can say is that we're going to stay on the Q&A box. We're going to go into the room now, the few of us, and Dr. Periman and Cian and Dr. Tam, Mr. Tam will actually start addressing some more questions for the next 15 minutes. So if you have any more questions, get them in and we will stay online for the next 15 minutes. You know, this is a once a year event, but I suppose people like myself, Mandy, Indy, we're here year round in Scope. And we're available at info@scopeeyecare.com. So we'll put that into the chat function. So if you have questions on products throughout the year, we're here to still answer those questions for you, even though you just see us on the screen once a year. If you would like to get more tips throughout the year, you can follow our social media channels. So we're going to just put some information on those into the chat function now as well. And of course, we want to be on this couch again next year. And in order to do that, we'd love to have your feedback and also hear from you what you'd like to hear from us next year. So on that note, I'd say thank you for 2024. I look forward already to 2025. And no matter where you are in the world, I hope you have a good rest of the day or a good evening.